Welcome to the first WooU event of 2022. This is going to be such an incredible event because we are talking about billing and coding updates, and we really want to get the year started off right, and hopefully everybody has a prosperous 2022. I am your host, Dr. Stephanie Wu, and I am the founder of Wu University. It's now my pleasure to introduce our first speaker of the day, and I think we are in for a treat learning from Dr. Soden, as he is incredibly experienced with billing and coding. Dr. Soden is a clinical professor and currently director of the healthcare department at SUNY College of Optometry. He graduated from SUNY College of Optometry and then completed a residency at the Northport VA Medical Center on Long Island. He remained at Northport VA for 26 years as the Associate Chief of Optometry Service. He was also a member of a large optometric practice in Lake Ronkonkoma in New York. He is recognized as a low vision specialist, and he's worked with the Commission for the Blind for his entire optometric career. He also serves as a third-party consultant for the New York State Optometric Association, and he's lectured extensively in third-party reimbursement and practice management. He is currently a member of the AOA's coding committee, and prior to this was a member of the third-party committee. So kicking off our event for today and our very first speaker of WooU 2022, welcome Dr. Richard Soden.
Thanks everybody and good morning. I'm coming to you from New York. If you're seeing my video picture, that's of Central Park, that a picture that I had taken probably sometime in early spring. So it's not like that today. It's a very gloomy day here on the East Coast. So it's a good day for us to really get together and talk about things that are going on. What I'd like to do today is to review the E&M coding changes that took place, the dramatic E&M coding changes that took place about a year ago. It's hard to believe that a year has actually gone by. And see what lessons we've learned. I do a fair amount of auditing of records, and I'm going to try and give you, through case examples, some insights into that. We'll talk a little bit about the new ICD-10 codes that started in October. I'm going to talk a little bit about the Medicare changes for this year. Not everything has quite been finalized yet. We're still in the middle of a Congress that hasn't necessarily fulfilled all its obligations to make sure things are ready by January 1st. And we'll talk about the new benefit package for routine vision care, which unfortunately did not happen this year either. So let's spend the bulk of the time talking about E&M coding changes that took place. This was indeed the first major change that took place since the 1990s. And it basically focused on evaluation and management codes for outpatient settings. Now, prior to 2021, there were some other changes that took place. Clinicians were able to focus on what was changed since their last encounter with the patient. For established patients, they can actually review and verify chief complaints or history that's obtained from an ancillary staff or from a patient outside of directly from you, and they don't really have to deal with checking boxes and all of those things. And we'll go through this in a great deal of time. I know that you're going to be hearing the last speaker today talking about proper documentation and what your records need to look like. But I'm going to say very many times throughout today's presentation that auditing is going to start again. It's been a little slow during the healthcare crisis of the coronavirus, but it is going to start going back on. I was on a Medicare seminar the other day, and they're back in business for doing things. So proper documentation is what really lies between you and the insurance company. It's what you have on a piece of paper, an electronic healthcare record, however you document things. That is really going to be the guideline for what an auditor is going to look at. It's going to describe what you did, what you performed, what your treatment strategies are. If you're doing any surgical procedures, did you obtain informed consent? Did you adhere to clinical standards? And is there medical necessity for a claim? Medical necessity is really becoming a very important component in auditing. The classic example that I've used in coding and billing is if you have blepharitis, there's really no reason to do a visual field. Computers are set up so carefully today and with such precision that they can match ICD codes to CPT codes and figure out what or not they're not going to pay for. So the new changes, as I mentioned before, basically apply to office-based codes. They may come back at some future point and added to other hospital-based codes. They got rid of the first level of code. They revised everything else. And the most dramatic change that really did take place was they're leaving it up to you as the clinician, you as the doctor, to decide what the history and what the examination elements look like. All right, that is going to be a physician-directed process. You're no longer going to have to do 3 elements of this and 6 elements of the HPI and 9 elements of an examination. It's really going to be what's medically appropriate for the patient at that time. The healthcare industry has recognized that many clinicians sit in front of a computer all day long and they just check boxes, and their interactions with patients are becoming very burdensome. So one of the reasons that they did this dramatic change was really to alleviate some of those burdens. So you're going to be basing E&M codes on either the medical decision-making or the amount of time that you spend with a patient. And we will go through case examples of each of these, including time. When I used to lecture dramatically and extensively on coding, we always know that we had the 9200 codes, the general ophthalmological codes, and the 9900 codes. I always recommended for medical billing that you use probably the 9200 codes unless your managed care contract said something different. Starting in January of last year, I really changed that opinion and said that I would do medical billing through the 9900 codes. They're going to be easier. They're going to be more representatives of what old medicine uses. And that's what I want to spend the bulk of time. The 9200 codes have not gone away. So if you feel you want to continue to use those, go ahead. We'll talk a little bit about them as we end the lecture today. And we're going to talk a little bit about prolonged service codes as well. And there were no changes last year, and I don't believe there are any changes going on to the 9200 codes this year. All right. So if you want to dilate a patient, that's your prerogative. It doesn't alleviate any medical legal issues, but you don't necessarily have to dilate with the 9900 codes anymore. That's up to you. In the system prior to the new definitions of these codes for the outpatient setting, if you were going to use a level 4 or level 5, dilation was mandatory. You can have care team members collect information, and it's not dependent upon a history of physical examination, either medical decision-making or time. So every record has to have a chief complaint, what's important for the patient's care, what do you need to know about it, what information is necessary to diagnose them. If somebody had a broken arm 20 years ago, it's really not, you really don't have to address it. You really need to address what's medically appropriate for that particular patient. So when, where, what, why, and how are the things that you're going to be dealing with. But again, it doesn't alleviate the need for medical legal standards of care. There are basically 4 different types of medical decision-making: straightforward, low risk, moderate, high. And it really refers to how complex is it to establish a diagnosis, to assess the status of a condition, and a host of other things that must be considered. Even if you decide that a person has a cataract and you recommend cataract surgery and the patient decides not to go for the cataract surgery, you get credit for that in the system because it was part of your treatment plan. The patient may decide not to follow that plan for a variety of reasons, but as long as you document what your feelings are and what your recommendations are, it goes into that. And we'll talk about that as we go through case examples. We don't deal with a lot of mortality in our optometric practices, or most of us do not deal with it, but we do deal with morbidity of both conditions and morbidity of complex problems in medical decision-making. You know, the visual consequences of a long-term glaucoma patient, the visual consequences of an uncontrolled diabetic. These have devastating effects on the visual system, body organ systems, and can be devastating to the patient. And those get higher level ratings in medical decision-making. I mentioned a few minutes ago that we deleted 99201 from the system. They both basically had the same medical decision-making. The only difference was really in the examination and history. And since they no longer use history and examinations, they deleted one of the codes. Now, you should all have copies of a chart that looks like this. I'm going to be referring to it when we do the case examples. The CPT office visit codes are off to the left. The level of medical decision-making is the second column, and then there are the three elements. And I will be going through all of these in detail. You have them in the handout. I'd rather spend time. If you have access to print a chart, this is probably one of the charts that should be in your possession whenever you're seeing a patient and you're choosing to use the 9900 codes. The chart is basically the American Medical Association's recommendation. And one of my colleagues actually put down in blue boxes the amount of time dedicated to all of these. So, and we'll go through that, but if you look at a low level medical decision-making in 99203, what that is saying for a new patient, it's somewhere between 30 and 44 minutes. But I'll go back over that again as we go a little bit later on. And everything I'm referring to basically is office visits. If you're going to be doing special testing like visual fields, gonioscopy, OCT, fundus photography, you cannot use those in determining and raising the code level for medical decision-making because the interpretation and report is part of those things. And I'll show you some examples later on. So let's briefly take a deeper dive into each of these three elements. The first is the number of complexities addressed during the encounter. There's a whole series of elements. So if I have a 99203, which represents a low level of medical decision-making, it's either two or more minor problems, one stable problem, and it goes on and on. I'm going to let you read these things. Risk is something you should always have in the back of your mind. What's the risk from the condition? What's the risk from the treatment? What's the risk, the long-term risk to the patient of the management approach that you're taking care of? Problems can include diseases, conditions, illnesses, injuries, symptoms, findings, complaints, many other things that are involved in seeing patients that we do. However, if somebody had a corneal foreign body 5 years ago, this is not a master problem list. So if it's not addressed, you don't get credit for it. So you can't really put any diagnosis or any problem addressed unless it's actually documented that you actually did it. And these are just different ways of looking at the same thing. I'm going to let you read a lot of these cases. I've given you some examples for self-limiting or minor problem. Some of these come directly out of CPT. Some of them are my own interpretation. So this might be a subconjunctival hemorrhage or a glaucoma patient complaining of itchy eyes. Stable conditions, those come out of CPT, but I've added a few examples over here of what might be optometric examples, and you can just go on. These lists go on. They're in the handout. I would suggest you read them. I can't memorize all of these things, but I think it's important to have a reference sheet for those things. They just can completely go on and on and on. So what I've done at some point over the next couple of slides, remember they have to be addressed, is that I've actually put them in a chart like this. So if you want to print this chart up, it may be easy for you to have this also alongside, and you can get some what the definitions are, and you'll see how we use those in a few minutes. The second element is the amount of data or complexity of data to be reviewed. And I'm going to show you examples that this is probably not the most important element in the three elements that we're going to use. It can be used. Data is a very confusing subject. It talks about the number of tests performed, talking to other providers, and I'll show you how that also is going to be used. Here's 4 different levels. You can review external notes, external tests. Reviewing previous charts do not count. Reviewing previous charts from your own office or from your own tax ID number, really, it's got to be from other sources. You can get information from independent historians, which could be family members, teachers, etc. You can talk to outside physicians, and documentation is really important. I teach students this sometimes, and I just give them some example. Instead of saying patient board and records from a referring physician, it'd be much nicer to say reviewed notes from the referring physician today. And patient board and tests from referring physicians, review what tests you actually brought in. Patient to have blood work, ERG, genetic tests, ordered blood work is certainly better ways of going on. And you can read some of those on your own. So data also has 3 different areas. It's unique tests, it's things that you do, it's independent interpretation of tests, and it's discussion with other qualified healthcare providers. So tests can include a lot of different things, but specifically it's not tests that have individual CPT codes like visual fields, etc. You can't use those. And I think that if you look at this particular slide, it probably sums it up a great deal. Tests you perform in your own office do not, with their own CPT codes, do not count for the testing purpose of this particular component of MDM. Tests that you perform part of your examinations that don't have your individual CPT codes, like contrast sensitivity, breakup time, also do not include. If you're going to get tests from outside labs like CAT scans, MRI, or blood tests, yes, that would include. If you're going to review tests that are done in a different office, that counts also. So you're going to be looking at unique tests. If you're going to be ordering blood or things of that nature, remember that there are certain rules. CBC is one test, even though it has many different components. Cholesterol test is one test, no matter how many times you do it or the various different components that you wind up with it. And I'll show you an example of that right now. Dr. Smith is seeing Debbie. Dr. Smith's an optometrist. He has reviewed and summarized the medical records from her general PCP. He ordered some blood work and obtained a detailed history from her health status, or the parents of her health status. So if I look right over here, there are the 3 elements: tests, documents, and independent historian, independent interpretation of tests, and discussion of test management. In order to meet a moderate level, I need to fulfill 3 of the following. I reviewed prior history because it summarized it right over here. I ordered some blood work, and I needed her parents to supply some information for my examination. And that's exactly how data complexity would work. It's if there's a separate CPT code, or certainly things that you do in your own office don't include them, but blood work, MRIs, lab works certainly count. Who is an independent historian? There could be lots of different people. Here's the definition: a parent, a guardian, a surrogate, a spouse, a witness. Many of these people sometimes can supply information. If they do, it counts towards the data component of what's going on. And I showed you the slide before. I just wanted to put it again. Independent interpretation of tests. Let's say you don't have an OCT in your office, and you refer to a colleague for the OCT, and the person sends you back the OCT pictures, and you decide to review them yourself and you document it, then you can record that as part of the data components of what's going on. Same thing with VEPs, ERGs. And then if you talk to an external physician or other qualified healthcare provider, that counts as well. An external provider is someone not in your group, but someone might be in a hospital, nursing home, etc. It requires an interactive exchange. It's just not sending a report to that individual person. It can be done, it has to be direct contact, not through intermediaries. Sending notes don't count. It doesn't necessarily have to be on the same day as the encounter. It can be a day later, it can be a couple of days later, and it doesn't even have to be synchronous. It could be a phone conversation, but it can also be an email exchange between two providers, if that's the way that you actually want to continue along with the process that's going on here. So you can do it as long as you keep the documentation to support it. And here's the appropriate source, by the way. It could be a lawyer, parole officer, a case manager, a teacher, or other qualified healthcare reasons. So if we look at this table, I've split it down into the data element. There are certain things you need for limited. In this particular low-level, assessment requiring an independent historian is its own category. As we go into moderate or complex, they've moved that one into a different category. So to meet a moderate, you need to either have one of these three categories fulfilled. Much easier when I do some case examples, and to have extensive amount of data, you need 2 out of the 3 categories. And just another chart to show you how to look at these things going on. And I've just posted it a slightly different way. It'll make a whole lot more sense when I show you some case examples. Medical decision-making, third element, is the risk of complications. Here's where you start to think about morbidity and mortality of the patient. Again, 4 levels. What's the risk associated with a diagnosis? And I think you should always be thinking about what's the risk associated with the loss of visual function, and deal with it. Over there, it involves diagnostic procedures, medical decision-making with the family. They have to be documented and explained to the patient, all the options that exist, whether they take them now, whether there's something to monitor. All of those have risk factors associated with it. This is the chart again with the different levels. These are only some examples. I want to bring your attention to moderate level of risk. When you prescribe when it's prescription drug management, when you prescribe a drug or you reinforce it, it automatically brings the risk up to a moderate level. Decision regarding minor surgery, that's over here. Decision regarding elective major surgery. And I think one that many of us deal with all day long is diagnosis or treatment significantly limited by the social determinants of health. We'll get back to that a little bit later on. High risk has all of these things, and they're only examples. There are definitions of minor or major surgery, elective or emergency surgery. You can read a lot of these things on your own because it becomes challenging to do this. Morbidity is a state of functional or visual impairment. Quality of life is impaired. Organ damage may not be transient even with the treatment. Function is limited. Very significant for many of the patients that we see. Think of your advanced glaucoma patients with limited fields, your diabetic patients, your macular degeneration patients, optic atrophy patients, some head trauma patients. Social determinants of health is becoming a really significant component in how we examine patients. There have been studies, and there are just some examples of the major categories that are going on, but it also includes lacking of insurance, access to limited access to medication. So if you see a patient that can't afford his or her medication, the risk becomes greater, and so does the E&M coding level become greater. This is a study that was done many years ago that talks about, actually it was done in 2007 and then revised in 2015, which really talks about the fact that the living conditions of a patient, the ability of the patient to speak English or whatever their language is appropriately, may account for more than 50 to 75% of their total healthcare outcome. Basically, that means what we do in our offices probably is about 30 to 40% of the outcome. They don't follow up for a multitude of reasons. Any of these on this chart, it significantly reduces your ability to manage that patient. From an E&M coding point of view, you get additional credit for that. You also try and figure out ways of helping the patient do things better. There's a whole series of ways that eye care providers can impact the negative social determinants of health issues, whether it's getting access to care, talking about diet and exercise, education, referral to social service agencies, a whole series of things that probably worth a complete lecture at some point by itself. ICD-10 came out with a whole series of codes that you can use that refer to the social determinants of health. These came out in October of 2021. ICD-10 goes on a October to September basis, so all new codes start in October. These are all active codes. It talks about problems related to housing and economic circumstances, problems related to upbringing. These are important to send to the insurance company so they have records of what's going on. And there is a consensus amongst healthcare economics individuals and healthcare individuals that the social determinants of health may be the most important component in the MDM puzzle. So is the person unable to go to the pharmacy and get the prescribed medications? Or in many of our cases, can they actually see the medication bottles? Do they have a support system? Is the patient capable of remembering to take the medication? Is the patient anxious or upset? Are they homeless? All of these are going to affect your overall treatment of what's going on. So there are the three components of what you need to know about. You have the number of complexity of cases, the data, and the risk of complications. In the old E&M system, if you were seeing a new patient, you had to fulfill all three of these requirements. And for an established patient, you only needed to fulfill two of them. In today's new E&M coding for the outpatient setting, both for established patients and for new patients, you just have to fulfill two of the three. So they made it a whole lot easier. So if I have a moderate level of complexity, an extensive amount of data review, and risk of complications, what I basically do is I drop the lowest element and then I build the lowest of what's left. So in this case, I would drop this one. I have a moderate number of complexity, extensive data, so I build the lowest number, which would bring me down to the moderate level of medical decision making. And then using this chart, you can actually do the exact same thing. And I will show you these in case examples as we move ahead. Another way of looking at the chart, This is everything I just said in a nutshell when it comes to data, risk, and problems. Let's get into some cases because I think that's the easiest way to teach you lots of these things. So here's a new patient referred for a cataract evaluation. You did a medically appropriate complaint and history. You did the appropriate examination. When it came to medical decision-making, you addressed two problems: cataract surgery, cataract, which you recommended surgery for, and there was also a history that the eyes were itching and you recommended artificial tears. The data was very limited. There was no blood work ordered. There was nothing else really going on. You may have reviewed some doctor's previous records for what was going on, and you decided to refer the patient for elective major surgery. So when I put that together, I had I had 2 or more problems over here. I had a limited amount of data, and I had a risk of complication. Whether this was a new patient or whether this was an established patient, it would be level 4. Now, the fee reimbursement for the new is a little bit higher than the established, but it's all been much easier now with only 2 of the 3 criteria. Again, I would encourage you to have a chart like this in front of you. An example of a primary open-angle glaucoma patient, someone who's well controlled, they're at their treatment goal. You continue with Zalatan drops or whatever prostaglandin you're using. That may be somebody with a level 3. Worsening, not at gold, and you add a new medication, that would bring you up to level 4 because your prescription drug management automatically brings you up to that level. Anterior uveitis, you're going to start with your diagnosis. You have an acute problem going on. You order a whole bunch of tests, HLA, B27, ACE, a syphilis panel, and you prescribe medication. It's going to bring you up to a level 4. So here's where we're going to really look at some really specific examples of what's happening. Here's a 67-year-old patient, history of cataracts, stating that the vision's been worse in the past 3 months, increasing difficulty driving and glare. Patient's medical history was reviewed, updated. They take over-the-counter vitamins. A comprehensive examination was performed, doing whatever you needed to do. Your diagnosis was nuclear sclerosis in both eyes, worsening. Patient referred for cataract surgery. You discussed the options, risks, benefit of proceedings with the surgeon. You sent a letter to the surgeon, and the examination took about 19 minutes. So over here now, we have an established patient, one chronic problem with exacerbation. Patient reported that the symptoms of vision were getting worse for him to see. So when I look at my chart over here, moderate tells me I have 1 or more chronic illnesses with exacerbation. So my level of medical decision-making for the first element is moderate, number of problems. There really was no data to review here. I didn't do any blood work. I didn't do any CAT scans. I didn't review any records, so the data is minimal. The risk over here is I discussed with the patient and I documented that there were no really major identified risk factors. That's why I had that element over here. When I look at the table and I just cut out these important components, decision regarding elective major surgery without identified elements brought me down to a moderate level. So I have a moderate number of complexity problems. I have minimal data, and I have the risk of complication to be very moderate. So I dropped the lowest element, all right, and I'm left with both a moderate complexity and a moderate risk of complications, and it becomes a level 4 examination of what's going on. Alternatively, you could do this based on time, or you could have used either a 92012 or a 92014 if you chose to do that. If you chose to do that with time, 19 minutes would have given you, since this was an established patient, only a level 2. You were much better off from a coding and billing point of view to do this based upon the medical decision-making and not the time, because your reimbursement would have been significantly different in this particular case. Now, time is not always your friend. We'll talk about that. There are some instances that time is much more useful in coding and billing. I probably would suggest most of the time it's just easy to do the medical decision-making and leave time alone. But there might be some low vision providers, or there might be some head trauma patients, or very complicated cases that time may be more beneficial. And I do have an example of that as we move later on. Here's a 70-year-old established patient with decreasing vision, 6-year history of retinopathy with insulin-dependent, fluctuation of vision, history of hypertension with retinopathy, elevated cholesterol. I did an examination. My plan was cataracts, increased pressure, worsening proliferative diabetic retinopathy, worsening hypertensive retinopathy. I contacted the PCP via the phone to discuss the case. I reviewed the PCP notes because the patient did bring in that information with him. I requested copies and I received copies of their labs prior to the visit. The labs were the hemoglobin A1C, cholesterol. I analyzed them, I interpreted them. My diagnosis was proliferative retinopathy with poor diabetic control. Cataracts were a new diagnosis. Glaucoma suspect was also a new diagnosis because I had increased IOP. Questionable hypertensive control, adequate cholesterol control after I identified and discussed this with the PCP. Really important, and I reviewed all the previous charts that came in. OCT was also performed and reviewed at the same time. So I have a chronic problem with severe exacerbation, which is posing a threat to bodily function. If the vision goes, everything else becomes challenging for that individual. So my high level is one or more chronic problems with severe exacerbation. So here's level high. Data, I did an independent interpretation of 2 laboratory tests. Each of these counts as a single test. So I only need 3 elements here. I also discussed the information. I also did an independent review of the lab tests. So I have 2 lab work, one review of lab tests. So I fulfilled category 1. I also discussed this with the primary care doctor. So I fulfilled 2 of these 3 categories, and that brings me to extensive amount of data. Here's a case where data can be useful. And there was no separate credit for ordering or reviewing the OCT that you did in your office because that's part of that procedure. I discussed the major surgery risks with the patient. We're referring them for treatment. And there was a high risk of morbidity to the ocular system. So I had high, extensive, high. Even if you felt the risk of complications is moderate, from a coding and billing point of view, it would have made no difference because I would have been I only need 2 of the 3, and I clearly had that in number of problems and amount of data to be reviewed. Alternatively, I could have done this based on time or 92014, as long as you had the proper documentation. If I did this based on time, so actually this was an established patient, so using MDM, medical decision making, it was a level 5. If I did it based on time, it only would have given me a level 4 because this was it would have gotten me down to this particular level over here. And again, I find that if you have the right documentation and you can support the documentation, using level 5s is appropriate. Now, not every patient in your office is going to come in with a level 5 code, but if the documentation is there, an auditor can look at this and saying you had the right number of complexity of problems, or the data elements were there, and the risk was documented, I feel comfortable that you can use level 5s. If you have a very specialty practice, highly glaucomatous patients or complicated patients, level 5 might be the way to go. Here's a 62-year-old new patient who appears confused, accompanied by his son, and the chief complaint was a follow-up of primary open-angle glaucoma. They brought in some previous records. Again, this was a new patient. They were concerned, the son was concerned about his dad's glaucoma. There was a history of POAG and POAG. Medications were taken, the eyes are dry. I reviewed previous records. They were taking medication for both the glaucoma and for the memory issues. I try to take a complete history, or the patient the examiner tried to take a complete history, and he actually had to go to the Sun to get fill in some information. Examination was performed. POAG borderline according to the previous records, the goal set was 15. Today it was 19. So it was not under control anymore, and the dry eye syndrome was a new finding. So the patient was told to continue with the latanoprost and add bromidine and sustain in the morning. Sun indicated that his father had little or no drug coverage and could not afford the medication. But you went ahead and tried to find some resources, and we gave him some samples. So this is a new patient. I have a chronic condition with exacerbation, and that's exactly where I am over here. I also have a new undiagnosed problem, which was the dry eye problem. Limited amount of data to be reviewed. I did look at some previous notes. There was no consultation with the physician. The Sun did give a little bit of independent history. So I would say this is probably a limited amount, but it doesn't really matter, because as far as the risk is concerned, I added a new medication. I told him to continue his medication. Prescription drug management does not mean you just refill the medication, but you review the existing medications, make sure the patient is taking it, and add new medications. And it's prescribed medication. It's not over-the-counter medication. But I also had a significant amount of activities that were limited by the social determinants of health over here, which is this particular risk that's associated with it. So when I go to code this case, moderate number of problems, limited data, moderate risk. It doesn't really matter that the data is not extensive to be reviewed, because as I keep saying, and will continue to say, I'm going to drop the lowest component and build the rest of it. So I get rid of this, and it becomes a moderate case of what's going on. So in this particular case, I bill a 99204. I did an OCT, and there's my 92133. OCTs are either unilateral or bilateral today, so you don't get credit for both eyes. You get credit for one or both, and I added a refraction. If I had done this based on time, I would have gotten the same level 99204, because 46 minutes would have taken me into this realm over here. Alternatively, I could have done this as a 92004 or a 92002, and I would suggest that you also know the fee differentials between some of these in running your practices. Here's a 48-year-old established patient in for an IOP check. Patient is taking medications, no new issues or symptoms, no significant ocular history or medical history. I did my examination. IOP was at goal, less than 14 millimeters for the patient. Controlled POAG, continue latanoprost. I went over it when he was taking it, making sure that if he was doing anything else or the other eye drops, that he knew how to deal with it. Told him to come back in 3 months for a DFE and an OCT, and let's say the time was 7 minutes. So here I have a chronic stable problem. Some people may say glaucoma is never stable, but I'm going to say that in this particular case, it's a stable problem. The amount of data is minimal. Anything you do with your own tests don't count. And I did discuss prescription management. I told him to continue what he was taking. I made sure he knew when he was taking it. I might have asked him to verbalize when he takes his medication. And that brings me up to prescription drug management, which the risk would be moderate for. So this was based on a low, minimal, moderate. I dropped the lowest one, and I take what I'm left with. So over here, this would have been a 99213. The time, by the way, which I believe was 7 minutes, doesn't even meet the minimum requirement for time, because for a 99212, it has to be at least 10 minutes. So time is not always your friend with some of these things that are going on, but we'll talk about that a little bit later on. Here's a 57-year-old new patient with an acute, painful red right eye. He reports the lower back pain, happened once previously, vision's hazy in that eye. There's some pain going on, history of hypertension with one medication. You did an examination, you diagnosed acute anterior uveitis, you ordered HLA, B27, ACE, and syphilis. 4 tests were ordered. You diagnosed Pred Forte every 2 hours. You ordered cycloplegia. You told them to come back in 3 days or sooner if the pain doesn't go away or start to subside. And you spent 24 hours with the patient. So I had one acute issue with systemic symptoms of unknown prognosis, and I got that right over here. So that gave me a moderate level of problems. I ordered 4 unique tests, all right? Remember, each lab test counts separately, but a CDC panel would only count as 1. So I ordered all of those, and I had 4. I only needed 3, so I'm okay with a moderate level, and prescription drug management was moderate. So I go moderate, moderate, moderate. There's nothing to really drop here because they're all on the same line. I could have done this based on time or 9200 codes. If I did this based upon time, it would have only given me a 99202. So again, as I said before, be careful with time. And we'll talk about that soon. Here's a 27-year-old established patient, acute new red eye, watery eye, no pain, typical run-of-the-mill viral conjunctivitis. Told him to come back if it wasn't improved in 7 days. Gave him some tears, cold compresses. Acute uncomplicated illness. All right, unless there was anything else going on that you might be successful, no data, and there was no, I gave an OCT medication and I told them to comfort, so there was nothing I can do. The risk was actually very low. So where I had a low number of complexity, amount of data was none or minimal, and risk of complications was really low. So this would be a 99213 scenario of what was going on. There's really nothing to drop over here. And this may have been more appropriate with 92012. 6 minutes was the examination with the doctor's time. And again, this did not meet the complication, the time limit, because it was only 6 minutes. So you couldn't have used time in this case in general. Here's a 42-year-old new patient, prescription vision, progressive vision change more marked in the past few days, history of keratoconus, notable pain, history of contact lens wear, but he's reduced the wear due to discomfort and little vision improvement. Light perception in the right eye, 20/80 in the left eye. You diagnosed high drops in the right eye with apical scarring in the left eye. You prescribed antibiotic drops, hypertonic drops, cycloplegia. Previous records were reviewed, and you interpreted previous testing, and you called the previous optometrist, and you had a discussion with them. So I have a chronic problem with severe exacerbation. That eye with the high drops may need a corneal transplant somewhere down the line. The medications may not clear everything that's going on. The data, I talked to the provider what was going on. So I was able to fulfill this one. I also reviewed some of the old corneal topography units that were done at this particular time. So I fulfilled the independent interpretation of tests. This was the topography from a previous examination. If I had taken topography today, then you wouldn't have been able to use today's findings, but you reviewed this one, you documented in your chart. So you could have had an extensive amount of data that was going on because I met these two requirements, and I had moderate risk because of prescription drug management. So here I had a high amount of complexity of problems, extensive data, moderate risk, drop the lowest one, and your remaining level 5 code. Again, could have done either a 92002 or a 92004, depending upon everything else that you did. And in this particular case, if I did it based on time, I would have only gotten down to a level 3. This is the CPT code for the corneal topography because I did it today. But the point of this case is I also reviewed previous cases that were going on with this case. Here's a 66-year-old new patient referred by a neurologist, severe headaches in the right temple with decreased vision in the left eye, history of a brain tumor successfully excised, but the vision loss was down to around the 20/60 level, had an MRI, no new findings, patient was a bit confused, wife provided some history, you did a slit lamp was no, the neurological that you did was okay, you had a reactive pupil with cataracts, DFE showed a pale nerve head, you ordered some SED rate, creatine protein, CBC, diagnosis was suspected temporal arteritis, possibly AION, and cataracts. You called the neurologist who suggested that the patient be referred for a temporal arteritis biopsy. The neurologist prescribed a high dose of steroids, and you scheduled them for further follow-up. So here I have an acute problem with a threat to bodily function. I think everybody would see that that's a really, really serious problem. I ordered 3 tests, and I had an interpretation. I had an independent interpretation from his wife. The data was then excessive. The risk to the bodily function was extremely high. I also did some prescription drug management, even though you may not have prescribed it, you worked with someone who prescribed it. So in my experience, this is a high level of complexity, a high amount of data, and a high risk of complication. And this is a great example of where level 5 comes in. I would not be using 92004 and 92005. If I did it based on time, it only would have been 35 minutes. So that wouldn't have gotten me there. Couple of more cases. Here's an established low vision patient with a history of ARMD in the right eye. Left eye has history of NOP due to birth trauma. Best acuity was 20/70. Last exam was 3 months ago. I have a sudden loss of vision in the right eye. Dry AMD was the history, diabetes, hypertension, taking medication. You diagnosed a retinal detachment in the right eye. You had a stat referral to an ophthalmologist, and you called the ophthalmologist to discuss the case. So I have an acute illness with a threat to bodily function. Again, when it's appropriate, these high levels of problems addressed really, really should be used. Data was moderate because I discussed the case management. They didn't have a lot of testing to be done. You can't bill for extended, you can bill for extended ophthalmoscopy if you perform it, but it doesn't include in the test situation. And the risk was high because this was required emergency surgery. So here's 99205, high, moderate, high, drop the lowest one, take what you left, and do it at that particular level. I didn't even bother with indicating the time because this was clearly a 99205. Follow-up of diabetic eye changes, history of non-proliferative diabetic retinopathy OU, medically necessary history and examination was performed. I reviewed previous OCTs from my own office, diagnosed, assessed that the diabetic retinopathy was stable. I told the person to come back in 6 months for both an OCT and a DFE. So I had a chronic stable problem. The diabetes or the diabetic retinopathy was stable in my opinion. There was no data. Reviewing your own tests count as the test, so the OCT you did that day is not involved with it, and the risk was low level at this particular point. So 99213, get rid of the data, you left with that one, and that's a relatively easy case, or you can base it on time. Let's say I have a more extensive diabetic patient. I follow up a diabetic retinopathy, history of NVE, NVD, mild edema. Patient uses insulin every other day as he cannot afford to pay for it every single day. You did a medically necessary history and examination. You reviewed medication. You found that the proliferative diabetic retinopathy was worsening. You referred him for a retinal specialist for possible laser therapy. So I have a chronic problem with exacerbation. Right over here, clearly things are moving. Data is minimal. And I had a whole issue regarding social determinants of health there. Patients who can't afford their medications on an ongoing basis. This was the case where he absolutely was taking it every other day because he couldn't afford it. Those individuals need social service intervention. And finally, with this new coding system, you're able to get some credit for taking care of that. So we're going to build this, we're going to code this as moderate numbers of problems, limited data. Data doesn't account all the time for what's going on, but it's really not that important because you only need to fulfill 2 of the 3 categories. And I really would just build this at the moderate level. I also build an OCT and refraction and any other independent CPT tests that you might have performed. Just another couple of words about social determinants of health. There are many, as I said before, many important public health people are talking about the importance in this of care. And if you document it, it's really a critical component, both for the patient and it helps you with the coding process. That's what's going on. Here's a 48-year-old established patient for an ILP check. They're taking the medication. Everything looks great. And again, I think we've gone through that case enough before. Here's a 48-year-old established patient who lost his health care, lost his job and his health insurance, and is not taking any drops for a month as he has to pay for food for his family. It's either a choice of his glaucoma medication or food for his family. There were no new issues that were going on that he reported, except for the fact that his pressure today was 6 millimeters higher than the goal of less than 14 during a previous visit. Primary open angle glaucoma was controlled with medications. It was no longer the case. Education was given. Patient was also given information on how to contact the drug company for a possible reduced fee. Many drug companies will give indigent patients, based upon a certain economic level, the ability to get medications that are very reduced or sometimes free for a while. You also gave them some sample medications that you had from the drug representative that came in. You told them to come back 1 month for an ILP check. So I had a chronic illness with exacerbation, moderate level of problems, minimal data because you didn't get credit for anything you did. There was no outside tests or anything, but social determinants of health played a major role in what was going on. So moderate, minimal, moderate. Again, data is not the most critical element in many of these examples that I showed you today. So that's all the cases that I want to talk to you about regarding MDM. I think that's the way to go for the majority of the cases that we see. I think that's the way to go for medical eye care. I would probably recommend, my personal opinion, is to use a lot of these for medical eye care and leave the 9200 codes for either vision care or if your managed care contracts tell you to do that. Most insurance companies know that we do medical eye care these days. But let's talk a little bit about time. In 2020, time only was an element if 50% or more of the encounter that you spent with the patient was involved in either educating the patient or coordinating care of the patient, counseling the patient or coordinating care. Starting a year ago, January 1st, 2021, time could be used to code the entire encounter, as I alluded to in all those cases I just showed you. It includes face-to-face time and some non-face-to-face time. All right, and it's important for you to understand that certain things are included in the definition of time. And if you're going to use time to code, you have to document the amount of time when you started the exam, when you ended the examination, and you have to subtract the time for non-covered services. Time does not include the patient waiting in the waiting room for dilation, going into the dispensary to pick out glasses. It also doesn't include technician time and doing case histories. It's got to be face-to-face in that component, all right? And you got to document that. For those of you that may be involved in teaching institutions, I haven't really seen a great update in how teaching institutions are supposed to use time, but let's not worry about that right now. This is a list that CMS and the AMA put out, what includes time, and there's some very interesting things here. Preparing to see the patient. So if you're gonna review old charts and you want to include time, it's okay to do that because it's reviewing records, review of previous tests, as long as they have their own CPT code. Performing a case history, performing a medically necessary examination, counseling and educating the patient, ordering medications, referring and communicating with other healthcare professionals. When you're not reporting it separately, there are some separate care coordination codes. I don't know many optometrists that are using it, but I think the next element, which I've highlighted in red, documenting clinical information in the electronic healthcare system, is really for the first time a recognition that time can be used as long as it's not excessive time. If you see one patient and it takes you 4 hours to document, that's certainly not what they're looking to do. But documentation is critical. Independently reviewing results of tests that you may have ordered, like blood work and all of those things, etc. All right, time basically includes anything that you've done 3 days prior and 7 days after an E&M service. So things that you do in there really don't need to do it. It includes charting the day after the encounter, communication with family members. These are things that are not actually included in time. All right, time spent by staff, travel time, including communication the day after with a family member, time spent performing or visual fields, et cetera, are not included in time. Most important is clinical staff. Services that have their own CPT codes are not included in time. So if you're doing extended ophthalmoscopy or you're doing fundus photography, you have to take those out. So here's an example where a person is in the waiting room for 15 minutes. The examination takes 10 minutes. Refraction takes 10 minutes. Discussion with the family members take 5 minutes. The total time spent is 40 minutes. If someone looks at the chart of how much time is, that would be a 99215. But in reality, if you really do a little bit deeper dive into this, you take away the 15 minutes that the patient was dilating in the waiting room, you include the 10 minutes for the examination, you take away the 10 minutes for the refraction because it has its own separate CPT code, is not usually reimbursed by many major Medicare insurance companies. You include the discussion with the family members, and the total time is 15 minutes. So your 40-minute encounter, which would have been 99215 if you included the entire encounter, is really now a 99212. So you got to be very careful on how you document these things and how you coordinate everything that's going on. And these are the examples of the times. There are different times for new patients, and there are different times for established patients. I'm not saying you want to do this, but I saw some documentation guidelines which said something. I spent X amount of minutes with this patient today, reviewing charts from outside physicians, doing a medical evaluation, discussing with family members, coordinating care with an outside physician, ordering diagnostic tests from other facilities, and documenting the electronic medical record. That's probably what an auditor might look for in a case. I don't know that everyone has the time to do that. But again, I'm not recommending time all the time that's going on. Time has to meet certain standards. If it's a subconjunctival hemorrhage and you spend an hour and a half with the patient, I think an auditor is going to say, there's something wrong with that. Some questions that I thought were actually comical. Time-based, total time on a date of account was 22 minutes, and the clinician, not an optometrist, asked, what about the time spent discussing the recent fishing trip that the patient went on? And the response was, unless the fishing trip is relevant to the E&M management service, it's not counted. Again, just to go a little bit to the absurd. What about a clinician who's slow on the EMR? There's no time adjustment for being slow or fast. Lack of this efficiency for any reason is not rewarded in this methodology. So again, if you're going to be using time, auditors are going to be very careful. You're going to have to document exactly what was going on. So here's an established patient complaining of double vision after an accident. He fell down a flight of steps and hit her head, or she fell down a flight of steps and hit her head. You did a medically appropriate history and complaint. Again, you have to do that for both MDM and time. You did the appropriate examination. The exam started at 10:30. It ended at 11:05. It was 35 minutes. You had a long discussion regarding the diplopia that was related to the trauma. You advised the patient to return a month before recommending prism or therapy to resolve the double vision over time. So the exam started at 10:30. It ended at 11:05. There was no refraction that was performed. There was no there were no other independent procedures, and that included, I don't know, I can't remember if this was dilation. Let's assume dilation was not done at this time. It was 35 minutes. So this was an established patient, so the code would be a 99214. In the old system, there was a finite time. It was like 42 minutes for a certain level. They've made it a lot easier now because they put range of times in for what's going on. The only case that you may really want to consider using time is that if you are going to spend a tremendous amount of time with a patient, and let's say this is a low vision patient, or let's say this is a head trauma patient, or a patient that has a lot of questions or things that are going on with a specific case, they came out with some new codes called prolonged service codes. Now, these prolonged service codes were in the old definitions of outpatient E&M services. I don't know that many low vision patients that use them. I don't know that many optometrists that use them, except for some of the specialties. But if you exceed some of these time factors, and you have to exceed level 5, in the old system, you did your coding based upon history exam and medical decision making. And if it was a level 3 and you exceeded the time, you were able to build the level 3 and the prolonged codes. In the new system, you must exceed the level 5 for an established patient and the level 5 for a new patient. All right, you can go back and look at the chart. And every time you exceed it by 15 minutes, you could bill a 99417 for each additional 15 minutes. And it has to really be 15 minutes. and it really can only go to 99205 or 99215 for established patients. There was also a bit of controversy between the private sector and CMS, the Medicare, Medicaid sector. They couldn't agree on what the times for the prolonged service codes should be. AMA said one thing, CMS said another thing. So what CMS wanted to do was to replace the 99417 with a G code, G2212, due to the time dispute. CMS thought that the times were too generous that were promoted by the AMA. So if you're going to be seeing Medicare patients and you want to use prolonged codes, then you can, then you have to use the G code. If it's non-Medicare patients, you use the 99417 code, etc. It's only to be used with level 5 codes that have been going on. The best thing for me to do is to give you these charts and take you to a chart that looks like this. So if you look at the left for new patients, if you're less than 75 minutes, because the coding for an established patient is 60 minutes for level 5. If you go between 60 and 74, you haven't gotten to the level. The codes in blue are the Medicare codes. The codes in green on the right side of this column are the codes in blue are the CPT codes, the non-Medicare codes, and these are the Medicare codes that are going on. And if you use this chart, you'll see exactly how many times you can bill individual services. This is just a different way of looking at the same thing again. I think the easiest way for me to tell you this is to give you an example. A neuro-ophthalmologist sees a 45-year-old patient referred for an evaluation and management of slow loss of vision with unexplained etiology. Patient brings a copy of their complete medical record from the referring physician and the ophthalmologist, and they were reviewed today. Exam performed and discussed with the patients. 90 minutes was spent reviewing records from 90 minutes was spent with the patient, including reviewing records from the outside physicians, performing the examination, and documentation. So if I am seeing that patient today, I examine, and you don't have to be this detailed. I reviewed the charts, 15 minutes. I examined the patient, 45 minutes. I discussed with family members, 10 minutes. I documented 20 minutes. The total time was 90 minutes. No one that I know is actually saying that you need to do this level of detail, but this is just for clarification. So since this is a new patient and I was going to bill a 99215 based on time, and this was a non-Medicare patient, I'm allowed to bill 2 levels of 99417 because I exceeded the 60 minutes by multiple times. If this was a non-Medicare patient using the times above it, I can only do it for 1 visit. So this is that same case again. If it's less than 75 minutes, you can't bill anything else because you have to exceed 15 minutes. If it's 75 to 85 minutes, I can bill the 99205 and 1 unit of 99417. If it's 90 minutes, I bill two times. There's 105, and I keep going in 15-minute intervals. You have to really document the time and fulfill it. I think there are not many cases where this is going to happen, but certainly if it's appropriate for your practice, go ahead and do it. If it's a CMS case and it's 88 minutes, then you don't do anything separate. If it's 89 to 103, it's always the 99205 with 1 unit of G, 2 units if it's 104 to 118, and 3 units if it goes up to that. So I'd use these for some of your very extensive problems, for some of the patients that really are challenging. You might be spending a lot of time with an individual patient. They may have a lot of questions to ask you. And you know, if it's a low vision patient, what are the consequences? Am I going to go blind? Can I drive? If it's a young kid who maybe has albinism, that may be a case where you talk about the driving. If it's macular degeneration, let's say you're not doing a low vision examination, but the patient has a significant number of questions regarding of potential sight-threatening conditions, you may be spending 90 minutes with the patient. Head trauma patients, complicated glaucoma patients, it may be very, very, it may be a good time for you to think about those extended codes. You can only bill the extended codes if you're basing it on time. If you're basing it on E&M, you're not allowed to use those codes, and auditors will be looking for them. So I know I've covered a lot of material. We are on the downward trend, and I think there's lots of questions. So I may leave a little bit more time for questions than we originally thought. Documentation is really the key to all of these things. If you want to get paid for the services that you build, the documentation has to be there. Why was the service performed? How complex was it? What's the medical necessity? And I think the last speaker is going to go through lots of these things for you to think about. What kind of treatment was required, etc. Make sure that you have the documentation. And the more you have to work for something, the higher the level of medical decision making is. If you consider glaucoma surgery in the future, if the drops don't work, well, that's part of your treatment option. It raises up the medical decision making. Should I refer a macular degeneration patient for cataract surgery? There are cases, there are times when I was in practice when I did it. And again, it required a lot of discussion with the patient. It required a lot of discussion with the surgeon. And you know, that gets included in the time that you can bill if it's appropriate. Indicate why tests are being ordered. I see more and more times of audits going on where the doctor does not do the indication, the interpretation of reports for some of these cases. Why was the test done? What was found? And what are you going to do about it? Again, visual fields, extended ophthalmoscopy, corneal topography, the whole list. Whenever you go into a CPT book and you see that word interpretation and report, an auditor is going to look for that. Many electronic healthcare records have been modified that if you start to build some of those things, pop-up screens will come up. I did reference a couple of times today the 9200 codes. And again, we as optometrists and ophthalmologists have a dual coding system, which we're allowed to use. Nobody is saying you can no longer use the 9200 codes, but you do need to understand that there is no synchronization between the E&M codes and the RVUs and everything else. There was supposed to be some way of calibrating these two. When CMS looked at it, they decided that there was no crossover between the new 99s and the new 92s. What they ultimately did say is they are going to be reviewed, and what their future is really, really going to be determining by what CMS and committees like the RUC committee and the CPT coding committee wind up doing, and that's within the AMA. But when you're using it, make sure you know what the definitions are. No one's going to say that you can't use 92 for a macular degeneration patient, all right? Unless your managed care contract that you decide is really, really dictating to you. I know most of the vision care plans want you to use 9200 codes. Some of the medical plans may do that. So when you sign a managed care plan, I would strongly suggest you go in there. But you should be aware that the 9200 codes do have some elements associated with it. The history is not really well defined other than a chief complaint. There are 12 elements to a complete ophthalmological examination. These are the exam elements for both comprehensive and intermediate office visits. But there is also this definition that comes out of CPT that says you have to have a general evaluation of the complete visual system, a history, a general medical observation, which could be the patient was alert, the patient seemed to understand what was going on, external examination, ophthalmological examination. CPT does not mandate with the 9200 codes whether it has to be dilated or not, but it does require a gross visual field, and it does require a basic sensory motor examination. And I've reviewed cases where when these two things were not defined, they knocked it down from a level 4 to a level 2. So if you're going to be billing 92004 or 92004 or 92014, make sure that you ultimately have a gross visual field. What is a basic sensory motor examination? I also, besides doing low vision most of my career, I did a lot of vision therapy, and I have never found a great definition of a basic sensory motor examination. But for the purposes of this, I would actually define it as a cover test or EOMs or something like that. It also includes the initiation of a diagnostic and treatment program, and it has to have elements that are grade 8 or more of these elements typically for a comprehensive examination. So just be aware that if you don't have these things, you shouldn't be billing them. Most optometrists don't do gross visual fields or don't document that they did gross visual fields or a basic sensory motor examination. If you're going to be using the 92012, which is defined as the intermediate level, that includes history, general medical examination, external exam, other diagnostic procedures, initiation or continuation of a diagnostic treatment plan, and usually 1 to 7 elements. And if you don't have those, then you really can't understand it. You can't use that code. The other thing to bring out is that in the definition, in the introduction to the CPT code, there is a statement in there that a 92012 has to have a new symptom or a new symptom regarding an old problem, an existing problem, or an absolute new problem associated with it. And that many coders, many professional coders, many lecturers have said that if you don't have a new symptom with an old diagnosis or a new problem, you shouldn't be using 9200 codes. The American Optometric Association did some work on this, and they found out that that was an introductory statement. It's not part of the official definition. And when they added the initiation or continuation of diagnostic or treatment problems, even if you have a resolved problem, you are still continuing your program. So I don't think that's going to create any problems anymore, but you should just be aware that that's still there. And again, I would strongly recommend that you consider 9900 codes. I always include this slide. If it's not in the chart, it didn't happen. And if it did happen and the documentation wasn't complete, was untimely, or otherwise improper, you shouldn't be paid for it. You've got to make sure the documentation is there. You also have to make sure that you sign your records. A record is not official until it's signed. In the paper world, even single providers had to sign, single providers, solo providers had to sign the record. If you're doing electronic healthcare record and don't sign your record in a reasonable amount of time, usually 72 hours, and you're audited, they're going to ask you for the log. And if they see the record was not signed, they're going to say that that's not an official record because it was never signed off. There's no way 6 months down the line you can actually remember what you did there. Also remember, for medical optometric billing, it's Medicare pays for the diagnosis, as does most insurance companies, for the diagnosis and treatment of sickness and illness. And there has to be a chief complaint that's usually patient-specific or doctor-directed. So if your chief complaint is no change since last visit, I'm here for my annual examination, I have no problems, and you find the pathology, in theory, that is not a medical billed visit. Subsequent visits are. but Medicare and insurance companies pay for the diagnosis and treatment of sickness and illness necessitated by a patient's symptom. Chronic problems, I'm here for a 4-month follow-up of primary open-angle glaucoma. You told me to come back for my cataract check, etc. Those are acceptable. So also remember that. Moving ahead as to where we're going beyond telehealth, beyond E&M. Telehealth is still up in the air as to what the final outcome is going to be. Medicare and many insurance companies paid for very limited telehealth services prior to the pandemic. They've eased up a lot. They've actually almost allowed anybody to do anything in order to get the patient seen and taken care of. Where that ends, when this public health emergency does end, we're going to still figure out where it's going on. My gut feeling is there's a proposal to use telehealth for patients that have established relationships with clinicians. They may not do it for home visits anymore. They may not do it for therapy visits. Stay tuned. You're going to have to see really where things are going. I think there's a public health outcry that telehealth needs to be maintained. I think when you start thinking about the social determinants of health, it's also important to be able to talk to your patients. So there were certain modifiers that were available. They're still in effect until CMS declares that the public health emergency is over. There may be some geographic restrictions. Medicare really included only telehealth if the patient was in a remote area where there weren't that many clinicians. Now, basically, you can do everything that you want. There are certain, you get reimbursed for the same amount of money if you did it in your office or if the patient was at home. That may change. Telephone visits were acceptable, includes optometrists that can use these codes. So you're going to have to figure out exactly where this goes. Telehealth provided in places other than the patient's home is going to have a new modifier as we move ahead. And whether all of these things continue to be covered or not is still somewhat up in the air. So I would pay very close attention to where things are going with telehealth. But the important thing is to document that the patient verbally agreed to have this telehealth visit. That's really important. And if you're doing it with any of the time elements, make sure you write down exactly what the time is. Where the patient's location is, where the provider was, make sure you have the time-based services and keep records of what was going on. In 2020, there was a major change to extended ophthalmoscopy. Many people just weren't aware of this or still aren't aware of it. So even though this is a 2-year change that's going on, they took away the extended, or they revised the extended ophthalmoscopy codes. There used to be one for a new problem and one for an established problem. And they actually divided this into problems relating to the peripheral retina and problems relating to the central retina. So if you have glaucoma or macular pathology, it would be 92202. If you have peripheral retina problems, it has to include scleral depression of the peripheral retina. If your record doesn't indicate that there was scleral depression here, you should really not be utilizing this code. Still requires the 3 to 4 inch drawing. It still requires an interpretation and report. 2 things that they did do with this is they made it either a unilateral code or a bilateral code. So you're no longer going to be able to get reimbursed for both eyes. It's one eye or both eyes, so they cut the fee in half. They also said that you're not supposed to be using this code anymore when you're doing fundus photography. So they really took a really hard stance against extended ophthalmoscopy. I think there was tremendous overutilization of it. So remember 99201 scleral depression. You can use it for glaucoma patients. You're going to get paid the same for one eye or both eyes, and you can't do it the day you do fundus photography. ICD-10 codes that may be important for you to remember. I alluded to this before. There was a whole bunch of codes for the social determinants of health and psychosocial issues and socioeconomic issues that were going on. They tweaked a little bit about the long-term use of insulin whenever you see patients. There was an exclude one code, which means you couldn't use a couple of diagnoses at the same time. They've now made those, you can use them if they're appropriate. And there's some new guidelines for injectable non-insulin anti-diabetic treatments, oral anti-diabetic treatments. You still use the Z7984. And if it's insulin, you use the Z79.4. So again, diabetes is really continuing to evolve in the way things are coded. If any of you do Medicare screening, which does exist for patients who are 50, African Americans who are 50 years of old, Hispanic Americans 65, that come in with no symptoms, it's not a utilized code that Medicare, it's only a Medicare code. They did add a new Z code for that glaucoma screening for those conditions. There are a couple of CPT changes, nothing really significant. They took out the word pleoptic training and orthoptics. Again, I don't know many of you are using these. They added a new code probing of the lateral caniculi with or without irrigation. Some new surgical codes went in, injection posterior the chamber of the eye. There's some new digital equipment for amblyopia treatment that's existing. I'm going to let those of you that do those kinds of treatments in their office read those things on your own. They modified 99201, which probably nobody is using anyway, to delete the word presenting problems. Fee schedules have been updated. If you're not aware of how to access your fee schedule, you should go to your Medicare carrier. There are 13 carriers that exist in the country. Just type in Medicare carrier for Nebraska, or Medicare carrier for New York, and you'll figure out my Medicare carrier is National Government Services. Everybody has it. There's 13 of these. Some websites are better than other websites. We are Part B providers. You can get a fee code for every individual CPT code. Fee schedules are a little complex because it defines whether or not you do it with MIPS, without MIPS, whether you're a participating provider or a non-participating provider. I don't have a definitive answer on this as of yet. I think there was supposedly going to be a 10% fee reduction in the Medicare, traditional Medicare program starting on January 1st, 2022. My knowledge is that part of that was something for sequestration, which was a budgetary issue. They've actually put that temporarily on hold. It was a 2% reduction in Medicare fees. It may come back later in the year. All right, that's the best I've heard so far. And I believe that this decrease in the conversion factor, which really sets the stage of how they determine a fee, has also been on hold. Again, I think some of this is waiting for congressional approval. Medicare premiums have gone up. Medicare monthly premium has gone up about $21. If you make a certain income, it's all been rated or been subject to how much money you made. Deductibles have gone up. So I think it was $163 deductible. So now the Part B deductible has gone up. So you may want to find that chart useful. National government services and all the Medicare carriers have local coverage determinations. These are really important. So if you want to figure out how often you can do a CPT test for Medicare purposes, how many times you can do it, what are the codes associated with, what are the ICD-10 codes. These are great places for you to go pull up those policies. There are active policies, there are retired policies. My understanding, retired policies are still in effect, even though they may not have been updated. for a long time, but you could figure out what the codes for 92012 are for extended ophthalmoscopy. All of those should exist within it. It's a good resource for you to look at. Medicare has done a tremendous amount of auditing before the pandemic. They came up with all kinds of reviews. There was a search, there was a targeted approach. They pretty much all halted during the pandemic. But as of November, they are bringing this targeted review back, which means that if they think you may need a little education based upon your coding practice. I guess that's a nice way for me to say that I think there's something wrong with the way you've been doing coding. They will do a targeted approach. Don't ignore these. These are done to educate you, and if you follow the rules and understand what's going on, they can help you a great deal. Not everyone's going to get one, but it is available. They do follow the comprehensive CERT program. That's how much money they recuperate, and they recuperate a lot of money. Just you can see that in 2018, they figured out 8% of all billing was inappropriate. They do this for across the board CPT procedures, ICD-10 procedures. They do it also for optometrists, ophthalmologists. They do it for specific doctors. So if you ever get a cert, it's really important. That means a claim, there's a problem with a claim, make sure you answer it. And I look forward to you seeing a great deal auditing going on in the next couple of years, because there is going to be a significant increase. The MIPS program is still around. They've made some adjustments during some hardship adjustments. I know ALA is putting on a program in the next couple of weeks about the new program. The one major change for the diabetic eye measure is the eye examination must be performed by an ophthalmologist or optometrist, or when there is evidence that fundus photography results were read by a system that provides an artificial intelligence interpretation. So there is some new ways that they're trying to deal with the diabetic measure. Again, it's the same old system. You're going to get credit if you exceed a certain threshold. I don't know how many of you are doing that. And finally, I just did want to conclude on saying that back in November and January, back in November, December, it looked really, really like Congress was going to expand Medicare to include routine vision, dental, and audiology. Those services were supposed to have minimal costs and maximum benefit to patients. They were demanding routine vision, routine dental, and audiology. As the budgetary process moved on, and it's still not finalized as of yet, audiology was remained into the system, vision and dental were taken out. So it's not in the current bill that is being negotiated in Congress next year. Whether this is I think it's a good thing. I think it's a good thing as long as the benefit remains in the Medicare system. If it goes out to the routine vision care plans, I'm not so sure how that's going to factor into it. But in case you've heard about the expansion of Medicare to include routine vision, it's not going to happen this year. Stay tuned for future years and see where that goes. A whole bunch of resources for you to follow in case you want to read anything more. The final rules, every year we're going to get new rules. Every year we're going to have new things to deal with. And I know I've covered a tremendous amount of material. I hope that what you took away from here is that the new E&M system is not so complicated. It's certainly much easier than it was 2 years ago. And use it to your advantage. Use it to document the care, the great care that all of you give to your patients, and bill at the appropriate level. and you won't find yourself being audited. And if you are audited, you'll be able to substantiate those claims and follow the rules and document. So at this point, I know there's a lot of stuff in the chat and a lot of questions. So I'm going to stop at this point. I'll stop sharing my screen and we can go back to where we started.
Awesome. Well, thanks for all those cool cases. Like we said before the event began, just the cases are so important and interesting, and